Welcome to this space dedicated to the dissemination of scientific knowledge, designed for specialists, general practitioners, and students, as well as the general public interested in health. In this edition, we present a detailed analysis of the study titled Hepatic Angiosarcoma, a fundamental work for understanding the approach to this rare and aggressive primary tumor of the liver. This research was published in 2005 by Dr. Nahum Mendes-Sanchez and Dr. Ernesto Roldan Valadez. Throughout this video, we will explore how the team analyzed the clinical, histopathological, and radiological characteristics of this sarcoma, which represents a significant diagnostic challenge due to its low incidence and nonspecific symptoms, such as hepatomegaly and abdominal distension. We will also identify key findings regarding the importance of diagnostic precision through ultrasound, computed tomography, CT, and magnetic resonance imaging, MRI, as well as the role of histologic examination in confirming the presence of malignant endothelial cells. Legal disclaimer: this material is for educational and scientific dissemination purposes only. Its goal is to democratize access to the knowledge generated in specialized academic publications. Due to the dynamic nature of medical science, the information presented reflects the data available at the time of the original article's publication and may be subject to subsequent updates. Not medical advice. Under no circumstances does the information presented constitute a medical recommendation. The graphic resources used are only a representation of the article presented and are not completely accurate to human anatomy. For more information, you may pause the video.
Welcome to this explainer. Today, we're stepping into the shoes of a clinical detective to unpack a true medical mystery. We're looking at a totally fascinating, albeit pretty sobering, clinical case study that takes us from the absolute broadest strokes of epidemiology right down to the microscopic cellular level. We are going to examine the presentation of a condition so elusive, its symptoms literally masquerade as everyday ailments, completely hiding the aggressive pathology underneath.
Okay, let's dive right into this. We'll be taking a logical, step-by-step clinical journey today. We're going to cover the context, establish our objective, outline the methodology, review the key results, and then wrap the whole thing up with the significance and our conclusion.
Section 1. Context. A rare aggressive liver cancer. 0.5 to 2.5. Now you might be thinking, what is that? It's not a percentage. This is the incidence rate. 0.5 to 2.5 cases per 10 million people. Think about that for a second. Imagine a massive, sprawling megacity of 10 million inhabitants. In that entire sprawling metropolis, statistically speaking, only 1 or 2 individuals might develop this condition. It is shockingly rare. And that really emphasizes just how incredibly unlikely a clinician is to encounter this on, a typical Tuesday in the clinic.
So what exactly is hepatic angiosarcoma? Well, it's a rare and highly aggressive sarcoma that originates right in the blood vessels of the liver. And it strikes without prejudice, affecting both genders at absolutely any age. But here's the real danger of this condition: it's a total master of disguise. The signs are incredibly nonspecific. Patients might present with hepatomegaly, which is just an enlarged liver. Or maybe they have jaundice, ascites, that's fluid buildup in the abdomen, low blood platelets, known as thrombocytopenia, or even sudden internal bleeding. Because these symptoms are so vague and honestly could point to dozens of much more common liver issues, the true threat is usually hidden until it's highly advanced.
Section 2. Objective. Illustrating clinical presentation.
All right, let's meet our patient. We're looking at a 78-year-old Hispanic male. Now, his initial complaints didn't immediately scream rare cancer, right? In fact, he came in reporting a general sense of malaise, just feeling deeply unwell, along with some abdominal distension and rectal bleeding. And crucially, this had been going on for 3 months. That timeline is really important here. It's a slow, steady build of vague distress, creating a serious diagnostic puzzle for the medical team.
When the clinical team conducted their initial physical exam, the clues finally started to trickle in. They found that hepatomegaly, the enlarged liver we just talked about, and moderate edema, basically swelling in his lower limbs. Now, because of the rectal bleeding, they understandably ordered a colonoscopy, and that revealed ischemic colitis. That's a condition where blood flow to the colon is reduced. So the really crucial point here is that all these seemingly disparate signs, the swollen liver, the fluid retention, the compromised blood flow to the colon, they are subtly pointing the compass toward a major vascular or hepatic issue.
Section 3. Methodology. Evaluation, imaging, and biopsy.
Let's move on and see how this builds.
Because the clinical investigation followed a very clear systematic escalation. Step 1 starts broad, with the physical exam and lab work. Then, Step 2 brings in structural imaging with ultrasound and CT scans. Step 3 gets highly detailed with MRI imaging. And finally, Step 4, the ultimate truth teller, the liver biopsy. Let's walk through what each of these steps actually revealed.
Section 4. Key results. The 78-year-old patient's findings.
Okay, taking a look at the patient's blood work, it reveals a body in serious distress. Notice the platelets at 105,000. That's low. That's a condition called thrombocytopenia. The liver just isn't producing the proteins needed for blood clotting properly. And look further down at the ALT at 127 and AST at 81. Those are liver enzymes, and they are significantly elevated. Elevated enzymes are basically a distress beacon. They're telling us loud and clear that liver cells are actively being damaged or dying.
To see exactly what was causing this distress, the team turned to imaging, and comparing these two tools is honestly fascinating. The ultrasound showed heterogeneous echogenicity, which basically means the liver tissue looked completely uneven and mixed, with these dark hypoechoic patches. It told the team something was definitely wrong, but it lacked definition. The CT scan, however, brought the whole thing into sharp focus. It revealed a rounded, well-defined, hypodense image right in the right lobe of the liver that was entirely compatible with necrosis. And necrosis means tissue death. So they aren't just looking at an enlarged liver anymore. They are looking at a mass that is actively dying from the inside out.
Now, what's really interesting about this next set of results is the contrast between the MRI sequences. On the T2-weighted MRI, we see this massive lesion severely enlarging the right lobe, but bizarrely, it spares the caudate lobe entirely. It's almost like it's navigating around certain anatomical borders. But when they applied gadolinium, which is a contrast dye, for the T1 MRI, the lesion showed an incredibly important enhancement. It soaked up that contrast dye so much that it almost blended in homogeneously with the rest of the healthy liver. This proves the mass is highly vascular, it has a massive blood supply, which aligns perfectly with a vascular tumor.
And this brings us to the final piece of the puzzle, the histology from the liver biopsy. Looking under the microscope, the pathologist didn't see normal liver cells. No way. They saw plump, malignant, pleomorphic endothelial cells. Those are the cells that actually line the blood vessels. These cells had hyperchromatic, really dark, variable-sized nuclei. And honestly, worst of all, these malignant cells were observed growing right along the preformed sinusoids, the natural microscopic blood channels of the liver. I want you to picture this abstractly for a second. These cancer cells are essentially like invasive, chaotic vines, just aggressively wrapping around and overtaking the liver's natural structural lattice.
Section 5. Significance. The clinical relevance of the case.
So, why does all this matter? Here is why this explainer and this specific case is fundamentally so important. Non-specific presentations expertly mask severe pathology. Remember, this patient walked in just complaining of malaise and a bit of swelling. It is so incredibly easy to attribute those symptoms to age, diet, or just common localized issues. But clinical flags, especially combinations like a swollen liver paired with low platelets, absolutely cannot be ignored. They require aggressive, relentless diagnostic pursuit. This case proves, beyond a shadow of a doubt, that sometimes the quietest symptoms are hiding the loudest, most aggressive tumors.
Section 6. Conclusion. Concluding thoughts on angiosarcoma.
We want to leave you with a final thought to ponder based on the source material we've explored today. With symptoms that are so astonishingly nonspecific, how can modern medicine systematically catch aggressive anomalies like hepatic angiosarcoma before it's too late? Are we talking about better baseline imaging? Or perhaps more sensitive blood biomarkers? The answer to that question really is the future of early diagnostic medicine. Thank you so much for joining me to unpack this complex clinical journey today. Keep questioning the details and never, ever ignore the clues.
The reference for the article from which this information was extracted is displayed on the screen. Thank you very much for your attention and for joining us until the end of this analysis. If you found this review helpful, we invite you to share it with colleagues, residents, students, and anyone interested in these topics. Don't forget to subscribe and turn on notifications. This material is for educational and scientific dissemination purposes only.